Thank you for joining us. My name is Lily, and I am the Office and Billing Manager at Community Health Resource Center. Thank you again for joining us for our annual Advances in Breast Health and Breast Cancer Care panel presentation. I feel very fortunate that CHRC gets to be a part of such an important presentation every year. I'd like to share a little bit about our organization for those that have not joined our programs in the past. Community Health Resource Center is a nonprofit organization here in San Francisco. We were established nearly 40 years ago by doctors at California Pacific Medical Center to provide resources and care that would supplement their work with patients to support their overall health and well-being. Today, we provide 4 main areas of service: social work, nutrition counseling, community health screenings, and health education. And with that, I'll pass it along to Dr. Ann Peled, our moderator for today's presentation.
Thank you so much, Lily, and thanks so much, everyone, for joining. My name is Dr. Ann Peled. I'm a breast cancer surgeon and also the co-director of our breast cancer program here at CPMC. And we're really so grateful to get to be partnering again with CHRC for another year of our breast health and breast cancer awareness event. So just to get going and start some introductions of everyone who's going to be here. So with our program here at CPMC, I feel incredibly lucky to get to be a part of the program here and everything that they offer to our patients. So sorry, just to go back. So this is the largest breast imaging center in Northern California with over 44,000 imaging exams and procedures done every year. So it's a huge volume, and we get a ton of experience and get to really interact with patients in this way with these kind of large number of imaging related to breast cancer and breast cancer screening. We have this, which you'll meet today, multiple members of our multidisciplinary program, where we have weekly tumor boards and really focus on trying to bring all the different pieces, whether it's physicians, nurses, genetic counselors, nutritionists, other providers, research and support services all together to make sure that we're really getting everyone comprehensive care. There's also a huge focus on community outreach and education. We have multiple different programs helping make sure that we're getting information out to the community. And I know all of us love answering questions and are really excited that all of you are here to join us today. This is our Center for Women's Health. It's relatively newly opened at this point. We're well settled into the space over the last couple of years, but you're going to learn more from Jennifer Ma, one of our nurse navigators, about the process of coming in and what that looks like if you're a patient. We title this every year Advances in Innovations in Breast Cancer Care, and you're going to hear about some different ones today, but I just wanted to go over briefly kind of some of the things that I find are most exciting when we think about what's changing in breast cancer care. So first one, you'll hear more about this from Dr. Nazia Jafri, one of our radiologists. But we have significant improvements in screening and diagnosis. So we can better understand people's risks. We use factors like breast density, family history, and really can get a better sense of people, what their risk is, and then allow them to adjust their screening as a result. We also have more awareness of and access to genetic testing. You'll hear this from Tapia, one of our genetic counselors, but we're really at a place where people are more likely to want to have information about their genetic and makeup and what their risk is. And we're so lucky we can offer that here. And then finally, with all of this and understanding, we can really expand the types of imaging options we have. So here at CPMC, I feel very fortunate that all of our patients get to have, for instance, 3D mammograms with tomosynthesis, something that's better for dense breasts. We have other options of types of MRIs and other options for people, and this allows people to get a real tailored screening plan to help catch breast cancer early. Other innovations, we won't talk quite as much about these today, but really that whole idea that we're coming up with personalized treatment options. So we have a better understanding of what we call tumor biology. So really knowing, we don't treat everyone the same. It's not kind of a one size fits all anymore. It's you may have a larger tumor, but actually it's kind of more favorable from a biology standpoint. And so we can use that to help you really figure out what your risk of recurrence is and then tailor your treatment appropriately. So we now have amazing tests of tumors that actually help people make treatment decisions. So perhaps you don't need chemotherapy where 10 years ago we would think that you would have. Same with radiation therapy, same with how long you should be on hormone blocking therapy. So again, all of this really helps us figure out what is your personalized care plan and make sure we're not over treating or under treating you. One of my favorite parts from my plastic surgery and breast reconstruction side of things is this increased focus on survivorship. And I always think about it like we're in this place with breast cancer. For the most part, we have really excellent oncologic outcomes, and we can figure out how to have great cancer outcomes while still minimizing the negative side effects of treatment. In many ways, this allows people to, if not move past their cancer, at least have advancements that decrease the daily reminders of cancer treatment. So these include things like less invasive surgery, ways we can hide scars, ways we can keep sensation, ways to have targeted radiation therapy that allow us to decrease the impact of radiation on the breast. And so all of this, again, really shows the ways that we can improve breast cancer care, help people live better afterwards while still getting them great cancer outcomes. This transitions well into, we always hold this event on the third Wednesday of October, which happens to be National Breast Reconstruction Awareness Day. And one of the things we think about with this is that honestly, many people don't know that they have reconstruction options. They don't know that they can have reconstruction with lumpectomies or mastectomies. Coverage for breast reconstruction is actually federally mandated. And so this is a great opportunity to really inform people of their options, make sure we address disparities in care, disparities that we know about certain people not getting offered reconstruction in the same way. There's a lot of great information on plasticsurgery.org if people want to learn more about their breast reconstruction options. So to transition now into our program for tonight, as I mentioned, we have 3 fantastic speakers from our CPMC breast program. Probably what we'll do is have Q&A with each person after the talk if you have specific questions. As Lily mentioned, please feel free to put things through the question and answer. We'll answer them live, and then we may have some time at the end to answer some questions that would be broadly applicable for all of us. So thank you all so much for being here, and we'll go ahead and get started.
My name is Tapia, and I'm a cancer genetic counselor at CPMC Sutter. Along with my colleague Elizabeth Cart, we meet with patients to discuss genetic testing. So here's a bit of an overview of what I'm hoping to chat about today. We'll start by taking a look at hereditary cancer, discuss who should consider testing, discuss the benefits of testing, as well as go over genes that are related to breast cancer, what we might expect from genetic testing results, as well as implications for family members, and of course, advances in testing, as well as additional considerations for genetic testing. So it's important to keep in mind that anyone can develop cancer at some point in their life. That's why doctors recommend routine cancer screening at various intervals. Most cancers are considered sporadic, meaning the cancer happens by chance, often through a complex combination of several risk factors that can include environmental, lifestyle, as well as other biological risk factors. Some people have an increased risk of developing cancer due to inherited genetic mutations. Only about 5 to 10% of all cancers end up being due to a hereditary mutation, meaning there's an inherited genetic mutation passed on in families, which can cause individuals to have a predisposition to develop cancer. This is what genetic testing can help identify. So individuals and families who have a genetic mutation that contributes to an increased risk of developing cancer. Additionally, there are some cancers that are considered familial, where maybe there is a familial link suspected. However, individuals have already had genetic testing and no specific genetic mutation has been found. So a genetic mutation, also known as a genetic variant, is a change or alteration in the sequence of DNA that makes up a gene. Genes are made up of DNA, and our genes provide instructions for the formation of proteins for the most part. Genes associated with hereditary cancer syndromes are typically there to provide instructions for making proteins that help prevent cancer from developing. Therefore, genetic mutations or genetic variants can disrupt our genes, leading to damaged proteins that are no longer able to do their job to protect against developing cancer. So it's important to know that not all mutations or genetic variants are harmful, and we'll talk a little bit more about this a little bit later. So who should consider genetic testing? Now, I know there's a lot on this slide, but there are a lot of different considerations when going over someone's personal and family history of cancer. Genetic testing may be appropriate if any of these applies to yourself or a close blood relative. So keep in mind a close blood relative includes a first-degree relative, such as a parent or sibling, or sometimes secondary relatives, such as grandparents or aunts or uncles. It's important to know the type of cancers in your family as well as the age of diagnosis, because this really factors into whether someone meets criteria or not. So genetic testing may be appropriate if someone has either ovarian, pancreatic, metastatic prostate cancer, or male breast cancer, regardless of age of diagnosis. If someone is diagnosed with cancer under the age of 50, especially if it's breast, colorectal, or uterine cancer. This doesn't apply to all cancer types. For example, cervical cancer at a younger age is not typically indicative of a hereditary cancer syndrome. If someone has multiple cancers, so depending on the type, but generally if someone has had multiple cancers, such as bilateral breast cancer, or someone with breast and ovarian or colon and uterine cancers. Also, if someone has any of the above and is also of Ashkenazi Jewish ancestry, about 1 out of every 40 individuals of Ashkenazi Jewish ancestry have a mutation in either the BRCA1 or BRCA2 gene. As well as if someone in the family has already tested positive for a genetic mutation related to cancer risk. In that case, we know there's higher odds of family members having that same mutation. So what are the benefits of genetic testing? Knowing if you have an inherited mutation can really help you know more about your cancer risks and thus can empower you to be proactive about your health. If you already have a cancer diagnosis, genetic testing can help explain why it happened and inform your treatment plan, such as informing what types of surgery to consider or provide options for personalized therapies based on your unique genetic profile. If you don't have cancer, results can lead to an adjustment of cancer screening, either recommendations for earlier screening or more frequent screening than what's indicated for individuals at average risk. Enhanced surveillance can help identify cancer at its earliest, most treatable stage, which can make all the difference for more favorable outcomes. There may also be risk-reducing options that can be considered, such as preventative surgeries like prophylactic mastectomy to reduce the risk of developing cancer in a particular organ by removing as much of the at-risk tissue as possible. Patients can also discuss the option of taking risk-lowering medications called chemoprevention that can lower the risk of developing specific types of cancers. And of course, it can inform risk for family members. We'll talk a little bit more about that as well. So here are some genes that are associated with breast cancer. There's a lot of information on this page, but mainly what I want you to see is that there are several different genes related to breast cancer. Most people are familiar with the first two on the left. So genes BRCA1 and BRCA2, collectively referred to as the BRCA genes, which do represent the most common cause of hereditary breast and ovarian cancer. However, there are 11 other genes that are also related to breast cancer and equally important to test for when considering genetic testing for genes related to breast cancer. You can see that the lifetime risk to develop breast cancer is different for each of these genes. Some are very high risk, where the estimated lifetime risk to develop breast cancer is well over 50%, whereas as we move to the left of the graph, the risk is lower, closer to the average woman's risk to develop breast cancer, which is about 12 to 13% lifetime, represented by the horizontal dotted line. It's important to keep in mind that each of these genes may also predispose to other cancer types as well. So on this page, here's an example. The genes BRCA1 and 2, in addition to predisposing to breast cancer, also increase risk for ovarian cancer for women, prostate cancer for men, pancreatic cancer for men and women, and breast cancer for men. Additionally, the BRCA2 gene is also increases risk for skin cancer, for the skin cancer melanoma in both men and women. You can see that there's also even slight variation in terms of the degree of risk in either ovarian or prostate cancer between the genes BRCA1 and BRCA2. So it's really important to keep that in mind and know if you do have a mutation, the specific gene that it is in. So what can we expect for results? If you proceed with genetic testing for any gene that is tested, we can either get a positive result, a negative result, or a VUS result. A VUS stands for variant of uncertain significance. So a positive result means that a mutation was identified in one of the genes that was tested. If this is the case, so that's for a positive. An opposite of a positive would be negative, meaning no mutation was found in any of the genes that were tested. And then in the middle, a variant of uncertain significance, a VUS result, means that a genetic mutation or change was found in a gene, but it's a little unclear if this mutation actually causes an increased risk for cancer. So as we discussed earlier, not all mutations are harmful. Some of the times they just represent normal human variation. So what we know is that historically, most of the time when we do eventually learn enough information about uncertain results, they typically end up representing benign changes that are not disruptive and not associated with increased cancer risk. And therefore, anytime we do encounter variants of uncertain significance in testing, we treat them as negative unless proven otherwise. Keep in mind, it's possible to have a combination of any of the three result types, since typically multiple genes are tested at one time. If someone does test positive, their provider will review the cancer implications relevant for that specific gene and will also discuss the management recommendations with the patient. So if someone does test positive for genetic mutation, it means that that mutation was likely inherited from either mother or father and has implications for siblings as well as children. So this kind of inheritance is called autosomal dominant transmission. In this case, it means that each sibling and each child independently has a 50% chance to also have that same mutation. Keep in mind, mutations can be inherited from either mother or father. So be mindful of cancer history on your father's side of the family as well. It's important to not disregard that. And also, men and women have the same chance of inheriting a mutation, but obviously their chance of developing cancer may be different depending on the cancer types associated with that particular gene in question. Okay. So what are some advances in genetic testing? So different labs offer different sizes of testing. However, most offer multi-gene panel testing. What this means is that anytime we're doing testing, we're looking at several genes related to various different cancer types at once. Reviewing the family history before placing the test order can inform what genes should be included based on the types of cancers in the family history. Genetic testing also can now include RNA analysis. So DNA is used to create RNA, and genetic testing previously has only sequenced, meaning analyzed DNA. Pairing RNA with DNA can provide additional information to help identify and interpret DNA variants or mutations, even some that may not be detected by DNA-only approach. So paired DNA and RNA testing can improve mutation detection and help with classification, meaning reducing the odds of us finding those uncertain results. So it can really help improve the sensitivity and the clarity of genetic testing results. So what are some additional considerations? Now that you've learned about what to expect for genetic testing, how do we go about getting it done? So you can either meet with a cancer genetic counselor, such as myself, or testing can be ordered by your medical provider. Genetic testing typically requires a blood or saliva sample, which is then shipped to the genetic testing laboratory for analysis. It's important to note that the additional RNA analysis that I mentioned earlier can only be done via a blood sample. Now, results typically take about 2 to 3 weeks to be available. They do take some time. However, quicker results are available for people who need the information to make urgent treatment decisions. Now, whether or not insurance covers the cost of genetic testing really depends on your personal and family history of cancer. So does it meet criteria? This is typically reviewed prior to the test order being placed. And would be discussed by the ordering provider. It's important to know that many genetic testing laboratories do offer reasonable self-pay options for testing. So in the event that your personal and family history of cancer is reviewed, but you don't quite meet criteria, if it's something that you are really motivated to have, it can be done at an affordable self-pay cost. One other thing that we really like to make sure patients are aware of is that there's a federal law called Genetic Information Non-Discrimination Act, called GINA. It's been around since 2008, and it prohibits health insurance companies and employers from discriminating against individuals based on their genetic information. One thing to keep in mind is it doesn't apply to life, disability, and long-term care insurance. So these are things to keep in mind, but never a reason not to do testing. And certainly more in-depth discussion can be had at the time with your provider when considering testing. So that was all I had for you. Thanks so much for your time, and let me know if you have any questions.
Thanks so much, Daisy. I appreciate that. I think it's really helpful to have information, and I love that you highlighted the fact that genetic testing, the cost itself, if for some reason people don't meet criteria, which is something that I get asked a lot, that the cost fortunately is low and that many of the companies are willing to work with them. Excuse me, question for you. If someone is thinking, someone on the webinar, they have a family member who thinks they might be at elevated risk, do you usually recommend, should people start with their primary care doctors or the gynecologist? Like, should they reach out to you first? Like, what would be the process for someone who isn't coming through, let's say, with a new breast cancer diagnosis, or like is known to be at high risk through our breast center?
Yeah. So I always say, if anyone has any concerns about their family history of cancer, meeting with a genetic counselor is super helpful, because we can, collect all that family history information, go over, review which of those cancers are concerning, which of them are not, and then talk about the option for genetic testing. So typically most patients, I would say, inquire with either your primary care provider or your gynecologist, and they can place a referral to see a genetic counselor. And then, we typically go over a 3-generation family tree. So we ask about siblings, parents, aunts, uncles, grandparents, because we want to know who has had cancer, but also who hasn't. Because, if you have like 6 siblings and only one has had cancer versus 2 siblings and one has had cancer, the patterns are different. So assessing the patterns is really important. So, and like I said, we really meet with any patient who has any concerns about genetic testing, or their family history of cancer and the possibility of a hereditary cancer syndrome. And if they don't meet criteria, then we kind of go over that when we talk about what is a self-pay option. Is the patient interested in doing it that way? If not, labs also have like financial assistance programs that they can offer based on, income, things like that, to help if patients have trouble with that self-pay cost.
Perfect. Thanks. That's super helpful. And then another question that came on here that I'm sure you're used to dealing with, and I hear a lot as well, Daisy, is people asking, like, we hear a lot about BRCA mutations. We kind of know more about that, but sometimes some of the other breast cancer associated genes, PALB2 was one we had a question about, but some other ones as well that people may have heard of, like CHEK2 or ATM mutations. Could you just give a little information for people on how you think it's best maybe to learn about those kind of genes, and how you take into account people's family history when you're helping counsel people who may have some of these kind of less well-known genes for breast cancer?
Yeah. So each of these genes are very different, and so the cancer implications vary from gene to gene, as well as the lifetime cancer risk. So even all those 13 genes that are related to breast cancer, like we looked at earlier, the degree of concern for an individual to develop cancer differs from gene to gene. And so oftentimes we have guidelines that make recommendations about what ages to start screenings. So the genes that like BRCA1 or 2, or the couple other ones that hover around the very high risk, then that means typically that we're going to be making recommendations for earlier age to start screenings. And in general, whenever we do genetic testing, like if there's family history of breast cancer, we're not just going to look at BRCA1 and 2. Maybe we did like 15 years ago, but as long as you're testing like 2014 or earlier, then, sooner than that, then your testing likely covered a wider spectrum of genes, because it's hard for us to know when we're looking at a family history exactly what gene we're talking about. So any of those genes related to breast cancer are on our differential, which is why we're typically testing for panel of genes, so groups of genes. And then, beyond that, like, if we're seeing melanoma, then maybe we're thinking more, maybe it's a BRCA2, or maybe if we're seeing colorectal cancer, then maybe it's CHEK2, because that's also related to colorectal cancer. So really looking at the entire pattern is really helpful for us. But typically, because there are so many different genes that predispose to similar cancer types, we don't ever say like, oh, we think it's this. We'll just do a panel test to make sure that we're providing wide coverage of all those genes. And then if someone tests positive, then we can say, okay, now it makes sense, because yes, this gene is related to this and this cancer, which we're seeing in the family tree.
Perfect. Thanks, Daisy. And then maybe the last one for you before we move on is a question about what if someone doesn't know their family history? Kind of what would that potentially look like? Do we wait if someone is diagnosed with cancer and then we kind of figure out what to do, or what does that look like?
Yeah, so I know a lot of our assessments and whether patients meet or don't meet criteria is based on family history, and we don't always have that information. So most of the time we ask patients to gather as much as they can. So if, if relatives are estranged, maybe they have another relative who is on that side of the family who they do talk to, who can fill them in on the family history. But I know even that sometimes is not an option. Maybe patients are adopted and they really have no information about their biological relatives. In that case, it does mean that insurance likely won't cover the cost of testing, but it doesn't mean that you can't have it done. I meet with patients who, have concerns about hereditary cancer risk, and then ask their provider for a referral to cancer genetics, and we'll meet and discuss. So, what are the different testing options, and anticipate results, and if they're motivated, then they'll do it self-pay, and then we have information that's still useful. It's so useful to know that we've ruled out hereditary cancer syndromes, because then we can have some peace of mind that at least we know that aspect isn't there. It doesn't mean that people now have a 0% chance to develop cancer, but at least we've ruled out those known hereditary cancer syndromes.
Yeah, I appreciate that. I also would say for breast cancer as a concept, family history is just one part of when we assess people's risk of getting breast cancer in the future. So even if you are adopted or don't know your family history, don't feel like we can't still try to give you some information on your breast cancer risk, asking things about your own personal history of atypical cells or dense breast or other things that kind of go into risk calculators. So there are ways, even if we can't give you, exactly the information off the bat, we do have ways to to do that. So Jennifer Ma is one of our nurse navigators. I always tell people I feel so lucky to get to work at a place where we do have this coordinated care and have a situation where we can have someone see our nurse navigators after they've been newly diagnosed and get people to Daisy and Elizabeth, get them to us as surgeons or medical oncologists, and it really makes the whole incredibly scary process so much better. So Jennifer, I would love to hear you letting everyone know about what that looks like and going through the Breast Health Center.
To all, thank you for joining us. Again, my name is Jennifer, one of the nurse navigators here at the Breast Health Center, and I would like to discuss how the nurses can support you during your visits. So when you visit our center for a mammogram, a staff may call you requesting for a second visit to the center. The reason for this is because the radiologist would like to look at an area in detail, which may include a diagnostic mammogram combined with an ultrasound. So after the completion of the breast imaging, you might meet with one of the nurses to review the image findings and to discuss the radiologist's recommendation, such as a referral for a consult with a breast surgeon or a breast biopsy or aspiration. So the nurses are here to explain the biopsy procedure, what that entails, schedule a biopsy appointment, and to follow up with a phone call to let you know about the pathology results. Usually, we should have the finalized pathology result in 3 business working days. Additionally, the nurses are on standby to offer advice on how to manage post-biopsy complications. Now, if the results should be of an abnormal or malignant finding, the nurses are here to help you with the next steps. We understand that receiving information about cancer diagnosis can be very overwhelming and emotional for a patient to undergo. That's the reason why we have the NACAN Family Breast Cancer Recovery Program in place to provide extensive services to patients diagnosed with breast cancer. So what exactly does a nurse navigator do? Well, we're here to provide one-to-one support and guidance. We're here to review the pathology report with you and to help you better understand the characteristics about the breast cancer cells. Secondly, to provide navigation at the initial cancer diagnosis by facilitating a referral to a breast surgeon and to other specialists such as Daisy, our genetic counselor. Next, we also provide an overview of treatment options and providers involved in your care. Also to provide symptom management techniques while you are undergoing treatments with the different specialists. And lastly, to offer supportive resources and information to your questions so you can make well-informed decisions. So in addition to the nurse navigator, you will also have access to 3 other staff members to support you, namely our health psychology fellows. They offer one-to-one emotional support, as well as leading a support group for newly diagnosed patients. Second, we do have our registered dietitian here to discuss about nutrition and how to better strengthen your body. Next, we do have our social worker, and she's here to address your socioeconomic concerns, such as assistance in completing work accommodation requests, DMV handicap play card application, as well as family leave, as some examples that she can help you with. And lastly, our social worker can connect you with the local community organizations that provide transportation assistance and meal deliveries. I like to emphasize that these services are free of charge. I'd like to also mention that your case will be presented at our weekly interdisciplinary tumor board meeting with the attendance of our radiologists to review the images, pathologists to review the biopsy slides, breast surgeons, medical oncologists, radiation oncologists, genetic counselors, clinical trial staff, social worker, and lastly, the nurses. So this is a very interactive and dynamic meeting in which we discuss what is the preferred treatment plan that's tailored to you based on the biology of the cancer cells. So what happens next once you're done with treatment? Well, the nurses are here to provide you with a personalized survivorship care plan. Basically, the survivorship care plan is a written report that summarizes your treatments. It discusses what are some possible delayed long-term side effects that you may experience relating to the treatments. In addition, when and how often to do surveillance imaging and follow-ups with specific providers. And lastly, what are some lifestyle and behavioral factors to consider as you proceed with a new normal post-treatment life? So I hope this overview gives you an idea on how the nurse navigators can better support you and your family members. And we all look forward to helping you when you visit our center. Thank you.
Thanks so much, Jennifer, and want to comment again on how invaluable all of this is for people going through their journey. I wanted to ask a couple questions that I know come up with our patients that might be helpful. The first one is around, you mentioned kind of caring for patients and their families. And we all know that this, cancer really doesn't just impact our patients, it really impacts their families as well. And I just wanted to get a sense from you about what kind of resources or support you recommend to patients for their caregivers and what we can offer here, and maybe what would be other kinds of resources for them.
That's a very good question. We do have a social worker here in place who does provide mindfulness and caregiving counseling through our social worker. So she just started this session recently this month. So that is available for our caregivers as well.
Great. And then one other question someone asked about was sort of thinking about kind of integrative and supportive medicine and what that looks like. And I was just curious if you have patients asking about, what some kind of complementary and integrative medicine options might be, and how do they find out about those?
That's a very good question. So we do have our integrative for health and healing. Sutter here, and they do by acupuncture, massage. It's best to speak with your provider to facilitate the referral. So we do offer that as an integrative approach in managing certain side effects that you may experience relating to your treatments.
Perfect. Thanks, Jennifer. Well, I'd like next to introduce Dr. Nazia Jafri. She is one of our lead radiologists here at our Breast Health Center and is going to be talking about updates and advances in breast cancer screening. And I do see several questions related to that, and we'll get to those at the end if they aren't already answered in her talk.
Okay, looks like you guys can all see my screen. Basically, we're going to talk today about screening mammography, the what, when, and why. This is a topic that I'm very passionate about, and so I'll try to get through as much as we can in the next few minutes. So here we go. So just a little bit about CPMC and Sutter Health. Sutter Health and the CPMC Breast Health Center were really at the forefront of screening guidelines. Sutter recently made the decision to make sure to include in our preventive health guidelines that we do recommend screening mammography beginning at age 40 annually. Some of that was basically gleaned from data sort of internally, where our tumor registry demonstrated that between 2017 and 2019, 421 patients under the age of 50 were diagnosed with breast cancer. So young patients, premenopausal, and almost half of them, about 41%, were diagnosed by just their routine annual screening mammogram, which is pretty remarkable. The new cancers were predominantly stage 0 and 1, and that kind of led the path to really advocating for screening mammography in our patient population at 40. And we'll talk a little bit about some of the controversies later on in this talk. So some of the things I wanted to touch on briefly: the history of screening mammogram, the benefits, some of the terminology that you might hear in the literature. We'll talk about the controversies as well. And then if we have some time, we'll just touch very briefly on breast MRI. So the big take-home point from this talk is that screening mammography is recommended annually beginning at age 40 for the general population. It's the only imaging study that's actually ever been shown to save lives. And early studies that were done really didn't talk about risk in the transgender, gender expansive, non-binary, or intersex identities. And so that's a lot of the research, including currently going on, is in regards to this, as well as some of the racial and ethnic disparities in breast cancer, which I'll also touch upon. It wouldn't be a complete talk if we didn't talk about breast cancer statistics. And I know, whenever I talk to patients, they always say, like, I feel like I know so many people with breast cancer. It is because it is quite common. It affects 1 in 8 women in the United States, and it's the most common cancer among women aside from skin cancer. A woman in her lifetime has about approximately a 13% lifetime risk of having breast cancer, which is actually good news. It means that the majority of women will not have breast cancer in their lifetime. The median age of diagnosis in the United States is 62. And the American Cancer Society generally publishes estimates about the incidence of breast cancer, and about 287,000 new cases of invasive breast cancer were diagnosed in 2022, and approximately 43,000 women will die from breast cancer in 2022, 2023. We do know that when breast cancer is caught early, it's extremely treatable. And in the United States, mammography has actually been around since the 1980s. When it was first introduced, the mortality rate, so pretty much dying from breast cancer, the rate had been unchanged for about 50 years. And then after mammography was introduced, it dropped by almost half. So where are we now? I feel like I hear a lot from, colleagues and patients and friends that, it really feels like the incidence of breast cancer has been rising. And there is truth to that. Since 2005, the incidence of breast cancer has been slightly increasing, very slightly, by about 0.5% per year. And a lot of the research being done about breast cancer now is, why is that? The death rate since 2007 has steadily gone down in older women. However, it's actually stable in women younger than 50. So, screening at 40, and we'll talk about it more, is really vital. If you can see from that statistic alone, we do know that earlier detection saves lives, and treatments have drastically improved, even in the last 5 years. Most facilities have moved to the 3D mammogram from 2D, and just a little bit about that terminology. So 3D mammography is synonymous with tomosynthesis. 2D mammogram was sort of our kind of like workhorse mammogram. More facilities are moving to the 3D mammogram. I'll talk a little bit more about 3D mammography, and it tends to catch smaller invasive cancers earlier as compared to 2D. And here at CPMC, we actually do all 3D mammography at both of our sites, both at the Mission Vernal site and here at the Pacific Heights Outpatient Center. And we've been doing that since January 2020. So a couple images, if you've had a screening mammogram, you know what this looks like. We basically do, two views. When you have a tomosynthesis, you really won't be able to tell that you're having anything different than the 2D mammogram, except I'll show you a little schematic here. The arc will actually move around the breast while it's in compression. It takes about 10 seconds for image acquisition. And it kind of creates these sort of slices through the breast that the radiologist will then scroll through. Just to talk about COVID and its impact on screening mammography. COVID had a significant impact just across the board when it came to preventative care, which we're finally recovering from now. So there was about an 87% drop in mammography screening nationally from February to April. And one would say, well, that's not that many months. But if you can see from this slide, about 36,000 women because of that had missed or delayed diagnoses. And here at CPMC, we initiated a return to screening initiative where we reached out to providers with letters, essentially to encourage their patients to come get their mammogram. And that was really impactful. As I mentioned, we do 100% 3D mammography for all our patients, and some of the advantages are listed here. So it's better at finding smaller invasive cancers than 2D. The literature in terms of the numbers is all over the place. There's some studies that will even say 60%, but on average, it's about 35% better essentially at finding smaller invasive cancers. Over time, the recall rate, so how often patients are recalled from a 3D mammography will reduce over time. And essentially what that means is if you've had 2D mammography your whole life and then you get a 3D mammogram, you probably will get recalled from that first 3D because we're seeing more. But over time, as we have comparisons, that callback rate goes down. And it's better at detection of masses and architectural distortion. And both of those two findings on mammography are more associated with invasive cancers. I always like to show this clipping. It's from a journal article, essentially when tomosynthesis came out. So Dan Kopans, who's a pretty famous breast radiologist on the East Coast, he recruited 400 volunteers who had essentially had a normal 2D screening mammogram to come back and get tomosynthesis for free. And basically they found 7 patients in that 400 population that had been told, screening, come back in a year, everything looks normal. And 7 of those patients actually were found to have invasive breast cancer based on the tomosynthesis. So this schematic is basically one patient, and it shows this is their 2D mammogram. Really hard to kind of tell that there's a spiculated mass here, but on the tomosynthesis images, you can see this sort of like stellate appearance. This patient actually had cancer in 2 locations. Here's the surgical specimen from her lumpectomy, and you can see them next to each other. When Kopans kind of went around the country lecturing about tomosynthesis, he used to say looking at a 2D mammogram is like looking at the front and back cover of a book, but looking at a 3D mammogram is being able to flip through the book. And I think most radiologists who interpret 3D mammography will tell you that that's a really accurate, nice assessment. So why does 3D mammogram outperform that sort of, workhorse 2D mammogram? It boils down to anatomical noise, essentially. So breast tissue is white, it's dense, and this schematic shows you these are sort of the things radiologists are looking for: masses, distortion. And if you can see, it gets superimposed on that dense breast tissue. The other thing that we look for on a mammogram is calcifications. Interestingly enough, I would say in general, most radiologists feel that the calcifications probably are better seen on a 2D, but sufficient enough, we can see them well enough on the 3D. So for calcifications, I think both of them equally perform, but for architectural distortion and masses, 3D mammogram outperforms the sort of our old 2D mammogram. And here's a schematic that shows that. So here's a mass on a 2D mammogram, kind of hard to see, almost just looks like sort of white white tissue, but the arrows help you know that something's there. And here it is on the 3D mammogram. You can see this actually turned out to be a cyst. It's just a circumscribed mass, but you can see the margins are much better delineated on the 3D mammogram. Here's an example of a breast cancer on a 2D versus 3D. So, hard to tell. This sort of to me looks like just below it, that dense tissue, but here it is on that 3D, and you can see that sort of pulling. This mass is associated with architectural distortion. Much easier to see on the 3D, definitely easier to walk by on the 2D mammogram. So improves detections of masses. So I know we're moving along pretty fast here. I did want to touch on the controversies. And, what's exciting is sort of hot off the press in May of this year is that the U.S. Preventative Services Task Force finally made the move to start recommending mammography at age 40. For several years, they had recommended mammography beginning at age 50. And I think that caused a lot of confusion, not only for patients, but providers, not knowing sort of, when to tell their patients to come for their first mammogram. My only criticism is that they've recommended it every 2 years until 74. I have an asterisk there because I did go on the site last night and, it's still in draft status. So I'm hoping that they will change their mind about that and recommend it annually. How the controversy arose is it wasn't just that the U.S. Preventative Services Task Force had initially said age 50, but it was also that the American Cancer Society wanted to sort of land in the middle somewhere. And so they recommended starting at age 45. And then they kind of got a little bit more nuanced and said, well, you should get your mammogram annually till 54, then every 2 years from 55 to 84. But you know what? Most of you should start at age 40. And you can imagine if you're a patient, how confusing that is. And also if you're a provider, it's sort of like very confusing to tell patients when to start. The National Comprehensive Cancer Network, American College of Radiology, and the Society of Breast Imaging have always recommended screening mammography at age 40. And that's kind of where I would say the whole preventative world is heading towards. So why should we start screening mammogram at 40? It really maximizes the lives saved from early detection. And there's a lot of statistical models that have evaluated this over the years. So what's some relevant information to know? Well, 1 in 6 women will be diagnosed with breast cancer in their 40s. And 3 out of 4 of those women actually have 0 family history and are not high risk. So we're catching those cancers in these women when they're essentially walking into the breast center getting their mammogram. One study showed that actually mammography cuts the risk of dying from breast cancer nearly in half. And then we also know that premenopausal breast cancer tends to be more aggressive. So for example, if you start at 45, it's essentially 5 years of screening mammography that hasn't happened. And that potentially, if there is something there at 40, has had 5 years to essentially grow. So, screening is not a one size fits all. And I think that finally those U.S. Preventative Services Task Force recommendations are trying to align with that. When there's been studies done about that, their initial recommendation of starting at age 50, it was found that about 1/3 of cancers would have been missed and resulted in about 6,500 to 10,000 additional breast cancer deaths annually. And the federal government had actually barred Medicare and private insurers from basing mammography coverage on those U.S. Preventative Services Task Force recommendations. So I think that gives a glimpse into how people really felt about those recommendations. We also know, and we're hearing more about the ethnic differences and genetic differences in screening, and I'll touch upon that a little bit. So we do know that Black women have a higher incidence of breast cancer below the age of 45, and also higher rates of aggressive breast cancer compared to all other racial and ethnic groups. And there's a lot of research being done on the disparities in breast cancer. They overall have a slightly lower rate of breast cancer than white women, but we do know that below 45, they tend to have an increased rate of breast cancer. Triple negative breast cancer, which tends to be a more aggressive, more difficult to treat breast cancer, is also more common in Black women, particularly before menopause. Hispanic and Latino women have lower rates of breast cancer overall. However, they tend to be diagnosed at a later stage. Asian American women overall have the lowest rates of breast cancer nationally, but they also have the lowest rates of screening nationally. So, overall, moving towards a model where we're offering annual screening mammography at age 40, it really diminishes the racial disparities and ethnic disparities that we see in breast cancer. So just in the last few minutes, I did want to talk about breast MRI. It's, we always talk about it. It's sort of our top of the line screening study that we have. It's very sensitive at detecting breast cancer. So you can see the number here, 81 to 100%, but the specificity is 80%, which is on the low side. So it's a problem of false positives, meaning a patient will come for a breast MRI. We see a lot of stuff, but most of that stuff turns out to be benign. Prior MRIs can help with accuracy, and it's very useful in conjunction with mammography for high-risk patients. So just a listing of who's high risk: people that have a greater than 20% lifetime risk of breast cancer, genetic risk factors such as BRCA, personal history of breast cancer. We also use it in what's called extensive disease planning. So if you've recently been diagnosed with breast cancer, we use it to screen the other breast and also to really assess the size of the breast cancer in the affected breasts. We use it to assess response to neoadjuvant chemotherapy, which patients are given prior to surgery. It can be helpful in recurrence and problem solving. So for example, if someone's had breast cancer and is now feeling a lump at their lumpectomy site, the clinical exam can be very challenging when it comes to assessing for scar versus recurrence. And sometimes the mammogram and ultrasound can also be confusing. So MRI can be a really nice problem-solving tool in that arena. So I know we covered a lot pretty quickly. So thank you. And I am available if you all have questions.
Thank you so much, Nazia. That was excellent and so thorough, which is so great. And all of the guidelines and things changing. It's so nice to have the latest update, which I really appreciate. So I was going to get through some of the questions that we have, and we'll maybe start with some of the ones related to our topics. I'm happy to jump in on some of the other ones for more specifics about breast cancer. Nazia, you touched on this a little bit about women with who should have MRIs, but we always the breast density question. So I think this is one, I both hear a lot. If you have dense breasts and you're getting 3D mammograms at baseline for your screening, how do you make a decision to tell someone, should they go on to ultrasound and MRI as other kind of supplemental tools versus just having 3D mammograms as their main type of imaging?
That's a really good question. I mean, I feel like I think this is where the clinical breast exam comes into play. I know that like in the literature, it kind of it fell off a little, where people were hearing that the clinical breast exam wasn't really useful. I tend to disagree with that. I think it's like a good way to sort of assess risk in a way. So say you have a really easy breast exam, but you have a dense mammogram. I think it's okay to not do a breast MRI in that scenario. So you have a provider doing an annual breast exam, you're getting a good 3D mammogram. I think that's pretty sufficient. On the other side, if you have a dense mammogram, you've got some family history of breast cancer, maybe not in the high risk pool, but your OBGYN who does your annual breast exam is like, oh, you've got a really challenging breast exam. I think MRI in that scenario is a really good idea. So I think honestly, the clinical breast exam can be used to kind of like help, guide people. And you bring up an interesting point in the sense that this lifetime risk, we have a lot of patients that fall into sort of like this 20 to 35%, which technically is considered high risk, but I would say most of us on this panel would consider that more intermediate risk, And so I think in that intermediate category, if you've got a pretty easy breast exam, you're getting your annual 3D mammogram, I don't think a breast MRI necessarily is vital. But I would say with a challenging clinical breast exam and then that intermediate risk, it could be a good idea.
Yeah, I love that. And I think a lot of this comes down to the patient conversations. I think it was so important that you highlighted that MRIs, I always say they give us more information than we want sometimes. And I think being prepared for the fact that you do have a really good chance, especially if it's your first MRI, for needing to be called back for something, whether it's a second look ultrasound or even a biopsy. And that doesn't mean it's not worth doing, but I think having that conversation with your provider about the pros and cons is so important. I also tell people, never get your first breast MRI before you have a huge vacation or something coming up, because getting that call on vacation that you need second look imaging is not fun. So I think, again, it's really trying, as we talked about, like personalizing it to the person. This is excellent. Nazia, can you explain? I think sometimes people who haven't gone in for diagnostic mammograms versus screening mammograms and then screening MRIs, it's all a little confusing. So can you just explain diagnostic and screening mammograms and MRIs and how we kind of think about them differently?
Yeah, definitely. So a screening mammogram is basically if you are completely asymptomatic. So you don't have a lump, your provider hasn't felt anything, no nipple discharge. So you basically walk in, we do your mammogram, and then it's read within 30 days. You get a letter saying, yes, you have a normal mammogram, we'll see you in a year. Or you might get a letter saying, we'd like you to come back for additional imaging. When you do get that letter, I would say the majority of patients who are recalled for additional imaging, it turns out to be benign. So definitely not necessarily a cause for alarm if you get recalled. The majority of callbacks turn out to be what we call superimposition, meaning it may have been the way the tissue was positioned. It could be dense tissue. So most callbacks are not cancer. The diagnostic mammogram is basically for if you have a symptom. So you felt a lump, your provider's felt a lump, you have bloody or clear discharge. And we also do diagnostics for focal pain. So if you can point to it with one finger and it hasn't gone away with, for example, your next menstrual cycle. We also, in our system here at CPMC, we offer diagnostic mammograms to all patients who've had a history of breast cancer. That system differs a little from some of the other facilities in the Bay Area. For example, UCSF does diagnostic mammograms on patients 5 years after their diagnosis, and then after that, it's screening. Here we offer it. If you want to come for a diagnostic, you can. Our patients, I would say, generally prefer that because the way a diagnostic mammogram is done is the radiologist reviews your images in real time. So we look at it, and then you're given results right away. We also will recommend diagnostic mammograms across the board at other places in the Bay Area as well. If you've got sort of dense, complex tissue and you've been called back numerous times. And the reasons for that are twofold. One is to alleviate anxiety. It's very stressful to be called back year after year. And the second thing is that when you do have complex tissue, you may need an additional view or ultrasound. And so rather than continuing to recall you, we'll do it as a diagnostic mammogram. Breast MRI. So the MRI terminology, screening versus diagnostic. A diagnostic MRI would essentially be in someone who's recently been diagnosed with breast cancer, and we're looking to evaluate what we call extent of disease and then screen the other breast. Most everyone else is getting a screening MRI, meaning it's an adjunct to your screening mammogram. And how we like to do those is ideally we like to spread it 6 months apart. So meaning you would get, say, your mammogram every October and you would get your breast MRI every April. So you'd be getting one screening modality every 6 months, alternating. So your mammogram date would be every October and your MRI date would be every April.
Perfect. Thank you. I think we're going to switch over to some other kinds of questions. And this is kind of, Daisy, primarily for you, but honestly, anyone can jump in, which is asking about thoughts about genetic risk calculation models, kind of the different models that we have for calculating risk, Tyrer-Cuzick, Gale, myriad risk. And again, this may be something, Nazia, you want to jump in as well. But Daisy, do you want to start kind of how we think about risk models, how you think about it in your practice?
Yeah. So we definitely do run risk models for patients after they've had genetic testing. So if we've confirmed that there's no hereditary mutation, we've ruled out hereditary risk, then maybe we're still seeing family history and we don't know why. So if affected family members haven't had genetic testing, then we'll want to utilize tools that can still factor in family history as well as negative genetic testing results, as well as other factors that can impact risk for developing breast cancer, like breast tissue density, things like that. And so we run Tyrer-Cuzick on patients, and sometimes that differs from if it's run by somebody else, or I think the myriad MyRisk. Generally, they all gather similar amount of information, but it'll also differ if, let's say, you don't put in those unaffected family members, then we're like what we talked about earlier, where you're putting in one aunt who had breast cancer, but maybe you have 6. So, so there's, you know, different things. They may look a little bit different, but I feel like generally they're around a like ballpark similarity, which gives a better idea of what a woman's risk is.
Perfect, thanks. And then Nazia, getting back to you, can you talk a little bit about automated breast ultrasound and how that plays a role in complementing mammography or possibly MRI?
Yeah, so it's a really good question. I would say historically, like the bigger centers in the Bay Area, and by that I mean CPMC, UCSF, Stanford, we'd all sort of taken the stance that you know, screening breast ultrasound, it's a useful modality, but it's going to pick up a lot. It's similar to MRI in the sense of the false positive issue. So it'll pick up a lot of stuff, but most of that stuff turns out to be benign. And it would mean patients would be getting more biopsies. And, you know, again, you know, for anyone who's had a biopsy, it's not an easy thing to go through. You know, they are very minimally invasive, but you're waiting for results. You know, it can be a lot, I would say. So, and if, you know, the detection of cancer, we're not really moving the needle that much and we're finding more benign stuff, you know, as a group, we've always felt like it's not the best thing. That being said, I think if used properly, it can be really helpful. So here at CPMC, we've been thinking about getting it. Renee, who is our imaging director, and I have been working together to sort of talk about having it in place here for our patients, and then sort of making a decision of who to use it in. And I think in the high risk population, it could be really helpful. And then that group that you mentioned where, you know, you are intermediate risk, maybe not necessarily at a level where you want to be getting annual MRIs, but you want some sort of added level of screening. I think it would be really helpful in that population. And so we're potentially thinking about getting it here for like I would say the 2025 would be when we would have it. In terms of, are we missing cancers because we're not doing what's called ABUS, automated breast ultrasound? I don't think so. We're fairly generous here at CPMC with our ultrasound. So if there is a question on the 3D mammogram, we do ultrasound patients very frequently here. There are some practices that are more hands-off with ultrasound, I would say. But you know, in our practice, it's very commonplace when you come to have a diagnostic to also have an ultrasound. I would say more often than not, patients would get an ultrasound rather than just get the mammogram by itself. But I think ABUS, if used properly, can be helpful. I have reviewed images from other facilities, and there's definitely a learning curve, I would say, in terms of looking at it. ABUS it's an automated system. So it's not handheld, meaning it's not a doctor or a sonographer actually scanning. It generates images that are then transmitted to the computer and you interpret. And so there's a little learning curve, I would say, and a challenge where, you know, in real time, if you're there as a radiologist or a sonographer, you know, you can turn on the lesion, make a decision. So with ABUS, there's definitely a risk of false positives, but I think it could be helpful in the intermediate risk population.
Excited that we are going to get that hopefully soon. Daisy, I think this is a question we can answer together, but it's a question about thinking about prophylactic mastectomy. So I think this is actually a generally good question. It's related to screening as well. If you have someone who's thinking about kind of when they should start screening or thinking about doing something for risk reduction, like a prophylactic mastectomy, how do you use their family history to figure out what to recommend for them when they should really start thinking about these kind of risk reduction or early detection options?
Yeah, so doing something like you know, preventative surgery is an option for some of those high risk genes. Certainly, you know, imaging is a really good way of detection. So if people really want to make sure that they keep their breast tissue, then there's ways to do that. And then considering about when, like if someone does want to have the prophylactic mastectomy, when is a good time? Generally, there are specific age ranges that are recommended for considering that for the specific genes. But we also definitely look at family history to help inform, because yes, we have general ideas about what empirical data is about what we anticipate risk to be when people have mutations, but also we want to see how that's manifesting in your family. I think that's a really, really, like if there is family history that's known, looking at what are the ages of diagnosis for your affected family members, especially if, you know, they've already had testing and we know that that individual's breast cancer was due to a genetic mutation. What was their age of diagnosis? And typically, at least for like, when we would recommend imaging, we typically say 10 years before that. So 10 years is kind of the good reference range for when we want to start incorporating either additional screening or consideration of intervention.
And I often tell some people similar kind of 10 years before when you're thinking about mastectomy. The question also included some questions about reconstruction options. And I think, you know, we're very lucky nowadays that most people choosing prophylactic mastectomies can have nipple sparing mastectomies, which we know doesn't put you at increased risk of getting breast cancer in the future, but does allow you to keep the whole outside of your breast tissue, breast skin, I should say, including your nipple and areolar tissue. So psychologically, a lot of people do much better with that. We have options now for ways to keep nerves and reconstruct nerves to help people keep sensation. And then we have lots of immediate reconstruction options. We're very lucky here at CPMC to have a group of breast and plastic surgeons who work together regularly to offer immediate implant reconstruction, immediate flap reconstruction. And we're also seeing a lot more people who are actually choosing to have something called aesthetic flat closure, which is people who don't necessarily want to have a formal breast reconstruction, but still want their chest to look nice and flat. And we can do all of those options as well. Nazia, one more quick question on here, I think, as a general concept is how do we think about when to stop screening from an age standpoint? I know that's kind of a tricky thing and it's very individualized, but as a general guideline for when people might stop doing annual screening mammography, if they don't have a significant family history, what age we look at for that?
It's such an interesting question. So, you know, when I was in fellowship in 2012, 2013, I remember it used to be, oh, stop screening at 74, which now that seems like crazy, you know, because it's basically the idea is you'd stop screening if you were not going to pursue treatment. And there's so many non-invasive treatment options at this point. So I think it is a conversation, you know, with your provider. But I would say, like, you know, if you're in good health and you would consider doing an excision or possibly, you know, taking a medication, then I think continuing screening is a good idea. I mean, for reference, we definitely have women into their 80s here at the breast center coming for screening mammography, and that feels reasonable. If you've got if you're active, have a good quality of life, and would still take a medication or undergo excision, and that sort of 74 starting point, it's really, I would say, if you talk to any breast radiologist, it feels very historic. So yeah, so I think, yeah.
No, I appreciate that. And I think for a lot of people, if it feels better to be continuing to get annual mammograms, certainly worth having a conversation with your provider about that, and it should get covered. Thank you, Dr. Horwitz, for your question about flap reconstruction. So for those of you who might not know, there are types of reconstruction we can do where we actually use your own tissue from different parts of your body and use that to reconstruct your breast. We often call this autologous or flap reconstruction. The most common types of reconstruction actually use tissue in the lower abdomen, and there are a couple different types. One is called a TRAM. These are acronyms, but it's basically where we use the rectus, kind of the six-pack muscles, rotated up to help fill the breast after mastectomy. And then there's kind of a more modern version of that called a DIEP flap. And basically what that does is allows people to actually keep all of their rectus six-pack muscles and just take sometimes the skin, or at least kind of the fat layer that everyone has under their skin, to make a new breast. As I mentioned, we are really lucky here with the talent we have from a plastic surgery reconstruction standpoint, and we have multiple, which is very lucky because not all places have this, multiple breast reconstruction surgeons here who are skilled in something called microsurgery, which is actually the ability to do these muscle sparing options and connect them with little tiny blood vessels in a way that allows them to be a natural breast reconstruction for people who might not want implants. So we here tend to do something called DIEP flaps to try to minimize the trauma to the abdominal wall muscles. And we think about that kind of as a less invasive form of breast reconstruction. A couple other questions on here I'm going to sort of answer broadly because some of them are difficult to know exactly without knowing clinical scenarios. But the first one is on asking about a postmenopausal person needing to take an estrogen lowering medication for stage 1 breast cancer. In general, when we think of the different components for treating breast cancer, one of the components that plays a role in the vast majority of people who have breast cancer is thinking about hormone blocking medications. And the reason for this is that most breast cancers are sensitive to hormones, estrogen and progesterone are the two. And the idea is if we can block those hormones from acting on breast cells, whether it's breast cancer cells and the rest of your body or breast tissue cells itself, that we can reduce the chance that cancer comes back either in your breast or in the rest of your body. So as a general concept, this is usually recommended. It's a pill people take from anywhere from 5 to 10 years after their diagnosis. It's generally recommended for most people. But I will say, as I mentioned at the beginning of the talk, we're trying to have kind of more tailored treatment. And so it may be if you're a person who has a very small cancer, doesn't have any lymph node involvement, that perhaps just doing surgery or maybe surgery and radiation alone, your chance of recurrence is low enough that you don't need to take hormone blocking medication. Or similarly, if you're someone who maybe has other risk factors for things from hormone blocking, you might not be the best candidate for it. So I would say in general, it's usually part of people's treatment, but it doesn't have to be depending on your situation. Other questions. What are the latest treatment options for triple negative breast cancer? So triple negative breast cancer is basically breast cancer that is not sensitive to the 3 receptors, estrogen, progesterone, and another receptor called HER2. And triple negative cancer has over the years been thought of as a more aggressive cancer and one that we really need to make sure we're treating more comprehensively to help people get good outcomes from it. As a result, there's actually been a lot of research put into triple negative breast cancer treatment. This includes things like immunotherapies. It includes a lot of clinical trials where people who have triple negative cancer will get treatment before they go to surgery. Then we look at their surgical pathology, and then based on what we see, if people still have some cancer left behind at the time we take it out, we may recommend other kinds of treatments for them. The other thing I'm very excited about is they are actually working on a triple negative breast cancer vaccine. There's a small group of patients who've already actually had the vaccine that they're working through at Cleveland Clinic. And so that will be really exciting to think about actually having vaccines as well. There's a question on here about getting a list of reconstructive breast surgeons. The Sutter Health website has is probably your best place to start in terms of looking at Sutter Health, CPMC, microsurgeons, breast reconstruction surgeons. But certainly, Lily, if someone reaches out to you about that question, I'm happy to just send a list. But there are a bunch of us in the CPMC system who do breast reconstruction. And then the last question we have on here is a question about updated chemotherapy treatment for breast cancer. Again, this is a pretty broad question. I would say that what we're really trying with chemotherapy these days is first and foremost to see who really needs it. So we have these genomic tests that I mentioned where we can actually test your tumor. And a lot of people that 10, 20 years ago would have gotten chemotherapy now don't actually, because we can actually look at the tumor and find out that it wouldn't be a tumor that would benefit from chemotherapy or would need chemotherapy. We are seeing more immunotherapy. We're also seeing more kind of active hormone blocking therapies that allow for treating different kinds of both localized and also more advanced hormone receptor positive breast cancers that aren't chemotherapy per se, but are targeted treatments that allow for treating those better. So I think on that, it looks like we answered all the questions. I want to thank all of our panelists so much for answering all of this and really being there. Lily, thank you again so much for hosting it. And truly, if anyone has any questions, I know all of us would be happy to answer anything. I think our nurse navigation program, starting with Jennifer and the rest of the team, is always a really good place to begin if you have questions about what to expect through this process, because they can help kind of send you in the right direction to talk to one of us if needed. But again, thank you so much, everyone, for joining us this evening.
Thank you all again for joining us for this amazing panel. And thank you to our talented speakers and Dr. Peled, our moderator, for taking the time out of your busy schedules to be here with us and to share such valuable information. I just wanted to add a reminder that this presentation was recorded and we'll be sending a post-event email in the next few days with instructions on how you can access the recording and share it with your loved ones. I hope everyone has a great evening. Take care.
Good night, everyone. Thank you.